Hello, my name is Phoebe Marty, and with me is Tyler Molinari. We're both students, fourth year students from the University of South Florida College of Pharmacy. We are both on our first APPE rotation on critical care. Dr. Camilla Dell is our preceptor. Today we will be presenting on Clostridium difficile infection, otherwise known as CDI, in the intensive care unit. The following is our presentation outline. So today we will be talking about the epidemiology, risk factors, pathogenesis, and diagnosis of CDI. We will also be talking about clinical presentation associated with CDI, as well as complications, medications that could possibly lead to CDI, so the antibiotic risk association. We're going to also talk about treatment options, prevention, followed by a short assessment. So our objectives for the lectures are outlined here on the slide. At the end of the presentation, you should be able to discuss the epidemiology, risk factors, pathogenesis, and clinical presentations associated with CDI, identify medications that may lead to CDI, assess pharmacotherapeutic options for treatment of CDI, as well as design a plan for prevention of CDI. According to the IDSA guidelines for Clostridium difficile, the definition of CDI should include the presence of symptoms, usually diarrhea, and either a stool test result positive for C. diff toxins or a toxigenic C. difficile, or even colonoscopic findings demonstrating pseudomembranous colitis. As far as the epidemiology of Clostridium difficile, it is a gram-positive spore-forming bacterium that usually spreads via the fecal-oral route. It is non-invasive and produces toxins A and B, which are what cause the disease. And the disease usually ranges from asymptomatic carriage to mild diarrhea, colitis, or even pseudomembranous colitis. Transmission within healthcare facilities largely result from horizontal transmission, so via environmental surface contamination, hand carriage by hospital personnel, and other infected persons as well. The CDI is also a leading cause of hospital-associated GI illness, and patients with CDI typically have extended length of stay in the hospitals. The two biggest risk factors for CDI are exposure to antibiotics, especially broad-spectrum antibiotics, and then exposure to organism, usually through admission to a healthcare facility. Other factors that increase the risk of CDI include older age, so normally above, gastrointestinal surgery, reduced gastric acid, mostly due to the use of antacids, so such as PPIs, and concurrent diseases such as inflammatory bowel disease, so IBD. Serious underlying illness, so other comorbid conditions, and the presence of other concurrent diseases place the patient at increased risk for CDI, especially if the patient is receiving additional antibiotics for other infections and also has longer hospital stay. As far as pathogenesis, as you can see with the picture, when an uncolonized patient is exposed to antibiotics, this normally causes a disruption of the microflora, so then it produces the C. difficile spores, which cause ingestion of it, and then you also have colonization. After this happens, you end up seeing the production of the toxins, the C. difficile toxins, so toxins A and B, and this ends up leading eventually to the clinical disease. The hallmark or the precipitating event itself is the actual infection through the disruption of the flora. As far as diagnosis, there are a list of stuff to look over. So clinical signs and symptoms are your first things you want to see in the patient, followed by stool cultures. So stool cultures are normally only used, only recommended from patients with diarrhea. These patients should be tested for a possible C. diff. You also have other diagnostic tools such as the nucleic acid amplification test, otherwise known as NAAT. These are considered to be superior to the enzyme immunoassay, so EAI, and are normally your standard diagnostic test for CDI. The other diagnostic tool available is also is the glutamate dehydrogenase, otherwise known as GDH testing. With clinical presentation for CDI, you normally see, it can range from asymptomatic to mild or moderate diarrhea. It can go as far as fulminant or even sometimes fatal pseudomembranous colitis. So C. difficile diarrhea may be associated with signs of mucus or blood in the stool, but these are sometimes rare. You can also see pseudomembranous colitis. Fever, cramping, abdominal discomfort, and even leukocytosis can be seen, but they're found in a lot more fewer patients. You can also see arthritis and bacteremia possibly occurring, but these are rare otherwise. As far as complications, they normally include dehydration, electrolyte imbalance, toxic megacolon, bowel perforation, hypotension, sepsis. You can also see renal failure, and if not treated correctly, could possibly all lead to death. With medications that normally lead to CDI, there are a list of medications. However, what we're focusing on mostly is antibiotics, because that tends to be the most seen causative agent that puts patients at risk for CDI. And these are broken down into high risk, medium risk, and low risk. And as you can see, the clindamycin is probably the number one causative agent. So clindamycin obviously is categorized under the high risk. You'll also see your cephalosporins such as ceftriaxone, mostly third generation cephalosporins. So ceftriaxone and cefotaxime, fluoroquinolones are also known to cause C. diffs or precipitate C. diff. So your Cipro, your Levaquin, and Avelox. With medium risk, you can see your Augmentin, possibly Zosyn and Unison, and other carbapenems as well. Your low risk, you see metronidazole, vancomycin IV. Notice it's IV, not PO. Aminoglycosides, such as gentamicin, can also put patients at risk. Nitrofurantoin is another causative agent as well.
Okay, so now we're going to talk about treatment options. The first thing that you want to do is make sure that the offending agent, if the patient's taken one, is discontinued as soon as possible, as this may influence the risk of CDI reoccurrence. If possible, you want to avoid use of antiperistaltic agents like Lamodal, as this may mask symptoms and precipitate toxic megacolon. By looking at this chart, it gives you a breakdown of the different treatment options that you have. So you'll notice for the initial episode, if it's mild or moderate, you're going to recommend metronidazole 500 milligrams 3 times a day for 10 to 14 days. If the patient presents with a more severe infection, at that point, you're going to administer vancomycin 105 milligrams 4 times a day by mouth for 10 to 14 days. If they present with a more severe infection that's complicated and the patient exhibits shock, megacolon, or hypotension, you're going to administer the vancomycin 500 milligrams 4 times a day by mouth with or without metronidazole IV, and that's going to be given 500 milligrams every 8 hours intravenously. Now, if the patient presents with complications of ileus or ileum, the vancomycin can actually be administered per rectum. You notice that here, vancomycin is actually given by mouth and not IV, and it's given by mouth as opposed to IV because it is absorbed poorly, systematically. However, fecal concentrations are high because the target of C. diff infections is to eradicate the organism which is localized in the colon. This makes oral vancomycin an ideal route of administration. Oral administration also avoids systemic toxicities of vancomycin like Redmond syndrome. You want to also consider colectomy for more severely ill patients. And then last but not least, you'll notice with the first reoccurrence, the patient can actually be treated the same way they were treated initially. For second reoccurrence, you can initiate a more tapered or pulsed regimen with vancomycin. If the patient presents with a third reoccurrence at that point, they actually consider, or you want to recommend the physicians consider what they call a fecal transplant at that point. So refractory C. diff infections. This basically presents when a patient's been treated for the occurrence of an infection, but the treatment actually fails. At this point, if the treatment that was initially administered isn't doing what it needs to be doing, they try to go with higher doses of vancomycin and again try what they call a tapered pulse dose regimen. Other options can include rifaximin or tigecycline. So, with the prevention of C. diff, healthcare workers and visitors must use gloves and gowns on entry to the room of the patient that's infected with C. diff, and the sole purpose of that is just to keep that infection isolated. That's extremely important because the last thing we want to do is spread the infection from ICU patient to ICU patient. We want to emphasize the importance of hand hygiene, specifically with C. diff, where soap and water or chlorhexidine are recommended. C. diff is a spore-forming bacteria, so alcohol-based sanitizers or anything that have alcohol in it, they're not effective. Also, you want to go ahead and recommend that the room is cleaned using chlorine agents or any other sporicidal agent. Make sure that the environment is actually cleaned up from any type of contamination to reduce the risk of any more C. diff infections. Also, it's really important to implement or emphasize antibiotic stewardship in order to reduce the C. diff infections to begin with. So at the end of the day, prevention's everything. So now we're going to go into the assessment questions. For assessment question number 1, what risk factors are associated with C. diff infections? I need you to select all that apply. Option A are proton pump inhibitors, so things like Protonix. B, older age. C, inflammatory bowel disease. D, abdominal surgery. And E, none of the above. Okay, the answers are proton pump inhibitors, older age, inflammatory bowel disease, or abdominal surgery. Other more common choices would have been exposures to both the organism or long-term antibiotics. Question number 2. What complications can be seen in patients with C. diff infection? Select all that apply. Option A, dehydration. Option B, anaphylaxis. Option C, electrolyte imbalances. Option D, bowel perforation. And option E, none of the above. Okay, the answers are option A, dehydration, C, electrolyte imbalances, and D, bowel perforation. Other examples would have included toxic megacolon, sepsis, and even death. Assessment question number 3. A patient prone to C. diff infections should avoid metronidazole, vancomycin PO, gentamicin, macrobid, if at all possible. True or false? The answer is actually false. A patient that's actually prone to infections with C. diff should avoid any of the high-risk antibiotic options, so things like clindamycin, your cephalosporins, specifically your third-generation cephalosporins, and your fluoroquinolones. Assessment question number 4. What is the recommended drug of choice to treat an initial moderate episode of C. diff? Option A, vancomycin IV. Option B, metronidazole. Option C, clindamycin. Option D, fluconazole. And option E, Bactrim. The answer is metronidazole. The first drug of choice treatment would be 500 milligrams 2 times a day by mouth for 10 to 14 days. Vancomycin is an option for more severe cases, but we need to make sure that it's vancomycin by mouth, not IV. And last but not least, assessment question number 5. What are effective preventative measures used in the ICU to reduce the spread of C. diff? Select all they apply. Option A, probiotics. Option B, alcohol-based hand sanitizers. Option C, isolation. Option D, hand washing with soap or chlorhexidine. Option E, gloves and gowns. The answers are isolation, hand washing with soap or chlorhexidine, and gloves and gowns. Probiotics are not recommended, and again, alcohol-based sanitizers are ineffective. Other options include antibiotic stewardship, things of that nature. Okay, with that, this concludes our lectures. Thank you for joining us, and these are our references.